want to do a little bit of, these are just some of the connections that I have so that you'll know that what I'm saying, I am a consultant for a number of the different products that are available. The objectives today are to understand a little bit more about what we mean about management and why treatment for multiple sclerosis is important, and maybe to settle some of the confusion about the wide array of medications that are now available that I'm sure you know about. Just as a kind of a review, it's recently been discovered that there are now about 1 million people. It used to be said that there were 450,000 in the United States with MS, and we now know that it's closer to 1 million, which is kind of what a lot of us thought. It's a condition that affects women a lot more commonly than men. It begins in early adult life in most people, but it's a lifelong disorder. And also, I think the most amazing thing about MS is how variable it is from one person to another in the severity and the way it affects people's lives, and we don't understand why all of those things are true. And the important thing is that life expectancy is really about the same for people with MS as healthier people without MS. It's a little bit different. So what that means is that MS begins in early adult life, but it's a lifelong condition, and that's why it's really important to understand how to manage this lifelong condition. I know there's some people that are concerned about MS 101. I already know all of that stuff, and I'm going to just sort of review some basics here so that we're all on the same page when we talk about management. What is it that we're managing? And I think you've all seen this particular picture, which is a diagram of a nerve that is wrapped in this material that's called myelin. And myelin is a jelly roll-like material that wraps around the axon, or the nerve fiber itself. And the myelin is really important to the efficient conduction of a nerve signal down the nerve. And what happens in multiple sclerosis, the traditional view is that multiple sclerosis causes damage to this myelin, and when the myelin is damaged, like this little piece that's missing, then the nerve signal doesn't get through that area quite as easily. And worse yet, not only does the efficiency slow down, but that part of the nerve, that axon, then actually in the end may die, so that the nerve is lost altogether. And we know that multiple sclerosis is a condition that's caused by an aberration of the immune system. What's the immune system? The immune system is what protects you from stuff that doesn't belong in your body. Generally, we're talking about infections, viruses, bacteria, cancer cells, dead cells. The immune system is very complex, but it involves detecting and clearing the body of all of these things that don't belong there. So in this diagram, on the left-hand side, is a bloodstream. And in the bloodstream are these lymphocytes. Here they're labeled T cells. They're lymphocytes that cruise around your body. These are the police cars that are out there looking for trouble. And those cells get sensitized to something that's wrong. It's like that police car that's cruising around that gets a signal to, there's been a bank robbery down on 1st and Main Street, and a description of the car and of the robber, and so then these cells go out looking for that thing that they're supposed to apprehend. They get into the brain, and in the brain is where, with the help of lots and lots of other components, the damage to the myelin is done. So I think that that's kind of a basic description of important things to know about what MS is. As we've already said, the signs and the symptoms of MS vary a great deal. If that attack on the myelin is in the optic nerve, it affects vision. If it's in the brainstem, it may affect speech and coordination. If If it's in the spinal cord, it may affect walking and bladder control. And these episodes vary a great deal in severity, and the symptoms of MS, as you know, may be intermittent with an attack or may be more chronic. This is a picture, again, that you may have seen before, and you may see, well, gee, I've seen that again and again, but I think this is really important. Every time I look at this diagram, I understand it a little bit better, that this is what we think is the overall course of multiple sclerosis for a large number of people. And what it is, this black line in the middle with the little blocks on it is symptoms. So here, this flat line means that there are no symptoms. And then, lo and behold, you wake up one day with some blurry vision in one eye that gets worse over a few days, maybe even complete visual loss. But then, lo and behold, it gets better. It goes away, and the person may get back to normal. But there is a risk after this has occurred that there may be more episodes. So here, you wake up in the morning with some numbness in the leg that works its way up the leg, and over a couple of days and up even into the chest, may involve loss of ability to walk, loss of bladder control, and it too may get better or improve, but not necessarily back to normal. So this pattern of recurring attacks is what's referred to as relapsing, remitting multiple sclerosis, or these are exacerbations or relapses. In a large percentage of people who go through this relapsing, remitting course, which begins early in adult life, when they get to midlife, 10, 15 years later, there may be a progressive form of multiple sclerosis, or what's been called secondary progressive. Progressive pretty much always involves walking. It may involve cognitive function or a whole variety of other things as well. But the point is that there's just a gradual worsening, and there may or may not be any of these episodes here. So this is the picture. Begins as a relapsing, remitting disorder, which at some point in time becomes progressive. These little arrows down in the bottom show new spots showing up on the MRI scan. And the point of that is that, so a new arrow every time there's a new spot on the brain scan. And a new spot on the brain scan is really equivalent to an attack of multiple sclerosis that may not even have any symptoms, but there's a lot more activity that we see on the brain scan than we even realize from somebody's symptoms is occurring. So again, there's two different processes that are going on. There's the exacerbations, the attacks, and then the more progressive phase that comes later. They look different on the MRI scan. They look different under the microscope. We think that these are very different processes, and they're different in terms of the age at which people experience these different courses. So let's talk about management of MS or treatment of MS. And when we talk about management, we can look at a lot of different things, like what do we do when somebody's having an exacerbation of MS? You know, what are the treatments that we give then? What kind of luck do we have in reducing the chances of there being more exacerbations? What about alleviating the symptoms that someone has who has multiple sclerosis? Those symptoms that are always there, not just the attack, but the symptoms that are more permanent. And preventing multiple sclerosis from getting worse once it's in that progressive phase. And then also considering, you know, how do we fix what's broken? How do we make people get out of the wheelchair and be able to walk again? So I want to touch on each of these areas. So starting with the alleviating the attacks. When somebody has an exacerbation of MS, it's pretty well accepted that there are treatments that may be helpful. That attack of optic neuritis that I described with waking up with impairment of vision or with the numbness or weakness in the legs that gets progressively worse. Generally, these are treated with steroid medications. it is optional. We know that there may be improvement even without the treatments, but people are more likely to get better faster if they're treated with steroids. And in the past, we used to put people in the hospital for intravenous steroids, and while that sometimes is done for people who are having more severe attacks, many of the exacerbations we can manage as an outpatient and even with pills rather than intravenous things. When steroids don't work or don't work as well as we like, there are other treatments that can be given that may be helpful in getting over that particular exacerbation. What effect these have on the long-term course of it is a little less clear. And then alleviating MS symptoms. I'm not going to go into this in detail because Dr. Shapiro will be talking about it. Will there be a time for questions at the end? Okay, you want me to go faster? All right, so let's save the questions for the end. Is that okay? Or are you raising your hand because you can't hear me or I'm not making sense? But okay, so we'll talk about the symptoms. Dr. Shapiro will cover more management of the symptoms. So probably the biggest advancement in multiple sclerosis, the thing that has changed this whole condition that's been around for hundreds of years, is that since 1993, we now have a whole raft of medications that we'll mention here in a moment that can reduce the chances of people having more attacks and can reduce the chances of going into that progressive phase that comes later on. But as I'm going to show you in some other slides here, that's very clear that these medicines have their greatest benefit, their greatest effect, if they're started early on. Here is a summary of all of the medications that we have now. There's more than a dozen. You may see the name of your particular medication in these flags. And there's more coming, that practically every week there's something new. And we can kind of divide these medications into some general groups. Those that we call platform, so immune modulator medications are medications that correct the immune system overactivity. And so the platform medications are the ones that have been around the longest. They're all injectable medications that one gives either subcutaneously or intramuscularly. I'm sure that many of you have had experience with some of these medications. And the nice thing about them, they've been around for 20 years. We're very, very familiar with what things to worry about with them. And what we've learned is that they're very unlikely to cause anybody any permanent harm by affecting other organs or causing other problems. Moderate efficacy. What that means, when you talk about how good is a medicine, you think about it in terms of the number of people that can be spared of having more attacks. So what I would say this means is that it works, these medicines work for a lot of people, but they don't work for everybody. There are people who are on these medications who still have more exacerbations or activity even with the medications. So then comes a range of medications which have a greater span of number of people that would be benefited by it. They can prevent things even in people who have had attacks on these platform drugs. They do carry some more concerns, some more risks with them. They're not quite as easy to go to sleep at night knowing that there isn't going to be any harm from these. But we've learned even with these how to look for the things that might be harmful. Those are intravenous medications, and then there is a number of oral medications, pills that you can take that also are things that can be effective and things for which we're we know or are learning what are the possible downsides and what we should look for when we're prescribing them. There was mentioned down here that somebody didn't want to talk about lymphocytes, so I'll be quick about this, but that cell that I showed in that slide of the immune system is a lymphocyte that's floating around in the bloodstream that's causing this damage. And there's different kinds of lymphocytes, and T lymphocytes are the ones that we have always thought were the ones that are causing the damage in multiple sclerosis. These are cells that get into the brain, and they do essentially hand-to-hand combat and have a very direct effect on damaging the myelin. Another kind of lymphocyte is called the B lymphocyte. B lymphocytes, we've always thought that really didn't have much to do with multiple sclerosis. B lymphocytes make antibodies. They make proteins which then get carried to some other part of the body, kind of like a guided missile, and may end up damaging some other part. So there are B lymphocytes that can cause kidney problems, or myasthenia gravis, or rheumatoid arthritis, or lupus, or other conditions. We always thought that the B lymphocytes didn't have much to do with multiple sclerosis, but then there were some medications that came along, this is between 5 and 10 years ago, where they used medications which deplete or do away with the B lymphocytes just to see what would happen. And lo and behold, they were very effective. And it kind of changed our whole view. And now, rather than believing that the T lymphocytes are the only things that are causing the damage, we know that the B lymphocytes seem to be necessary for the T lymphocytes to cause their damage. So it's kind of like the B lymphocytes allow the T lymphocytes to learn how to cause the damage. So we've made some great strides in the treatment for multiple sclerosis. I think many would say that it's really a different condition now than it was 25, 30 years ago in terms of the likelihood or somebody's expectation of living a long life free of disability from multiple sclerosis. We've made great strides, but there are still limitations. One is that none of these medicines cure multiple sclerosis. We can't stop it. None of them really reverse the damage that's been done. That is, at least once the damage has become instilled in the system, there really is very limited ability to get somebody out of the wheelchair and walk again, or to resolve things, especially symptoms that have been there for a long time. And once things get into the progressive phase, it's very hard to slow them down. Much easier to reduce the chances of new attacks, less easy to slow down progression or to prevent progression. And but there is increasing evidence, nevertheless, that if people are treated early on, that there's less likely that they're going to be converting to that progressive form. When do we treat? As I said several times, as early as possible. Just I'll mention here quickly some special circumstances. Multiple sclerosis, by definition, is recurring attacks over time. And how did we do? Oh, okay, so I'm seeing some things on my screen that you're not seeing, fortunately. It's multiple episodes in time and multiple episodes in different parts of the nervous system. So for the example that I gave in that first slide, somebody has an attack of loss of vision in one eye that gets better, and then somewhere down the line they have an attack of the numbness and weakness of their legs. That's multiple sclerosis, recurring episodes in different space and time. But what do you call it when the person has their first symptom? What do we call it when that person comes in with their optic neuritis, but they've never had any other symptoms? Can we really call it multiple sclerosis? And what we know now is that with some MRI techniques and things it is easier to determine that somebody definitely has multiple sclerosis, but using the MRI scan, we can predict what the likelihood is that there will be more episodes. So that person who has the attack of optic neuritis, if their MRI scans are perfectly normal, they don't have anything else, most neurologists would tend to just follow the course of that person, maybe repeating MRI scans, but not starting a treatment at that time. Whereas when you do the MRI scan, if there's lots of evidence that there's been other activity, then one would generally start the medication. And then another situation that's come up in recent years, the patient that goes to the emergency room with a headache, or they fell down and hit their head, or something or other, where they get an MRI scan that has nothing to do with multiple sclerosis, and lo and behold, it looks like multiple sclerosis. And this is called radiologic isolated syndrome. This is kind of slippery because there's a lot of things that we know can look like multiple sclerosis on a brain scan that aren't. And so these are situations where we may not start a medication right away, but rather spend some time in repeating some MRI scans to see whether it actually does develop. This slide shows the effect of treating early. So if this is the so this line here, the vertical line, is the degree of disability. So here is normal. Here's a person walking. It would get higher up on this line. They walk with a cane. When we get to the top of this line, they can't walk. And and this is time. So what happens over time? The red shows what happens if we don't have any treatment at all. If we just let things go, that population-wise, a lot of people are going to become unable to walk, to reach this highest level of disability. Whereas if medications are started right up front, that it's more likely that the eventual damage can be limited, less severe, and then if the treatment is started later on here, that is still better off than not treating at all, but not as good as treating it from the very beginning. So moving on, when we talk about management, what about fixing broken nerves? I mean, the damage that's already been done, the person that's been unable to walk properly for a number of years, what can we do to reverse that? And this is a lot more experimental at this point. Can we put myelin back on the demyelinated nerves and make them work again? Not necessarily, because there may be some permanent damage. Nevertheless, there are a number of trials of things. We do have cells in the body, the oligodendrocytes, that make myelin. And so theoretically, these cells could be revved up to make more myelin. These cells that make myelin have a stop switch, so that otherwise we would all be one big ball of myelin if they just kept making myelin forever and ever and ever. So there's an off switch. And so the whole research here is, how do you find that off switch and make them start making myelin again? And there are some trials, in fact, that give this particular antibody, this anti-LINGO antibody, to see whether it will put myelin back on. Even though, this is a medication that's given very early on. So it's when somebody is actually having the attack, to give them a remyelinating medication that starts putting the myelin back just as soon as it's been destroyed. So it's a lot less clear, is that going to work in myelin that's been damaged for a number of years. And there are other kinds of antibodies that have been experimented with, and there's a great deal of interest in medications, some of which you know about from the internet, that look in the test tube like they ought to put myelin back on nerves, but we're still kind of a long way from showing that they actually do make a difference. Stem cells. What an amazing field. Stem cells is a very exciting field. Stem cells are cells in the body that have not been specialized. So a stem cell can turn into a liver cell or a heart cell or a brain cell or a myelin cell or anything. They're uncommitted. And so there are many, many ways that stem cells have been considered for a number of different diseases. And I'm sure that you get a lot of education about that on the internet, but the important thing to realize is that there are many, many different ways that stem cells are used for different disorders. So just because your neighbor had some stem cells injected into their knee joint when they were having arthritis and said that it worked, it doesn't necessarily mean that that same principle is going to apply to multiple sclerosis. But there are two kind of general ideas. One is to replace the immune system, and the other is to repair the nerve cells that are damaged. Now, as we said in that earlier slide, it's the immune system that has gone awry. There's something wrong with the individual's immune system that causes this damage, or that enables it to cause this damage. So, why not just get rid of the immune system and put in a new immune system? I think there's something political about that, isn't there? If you don't like your government, just get rid of everybody and vote in a whole new bunch and everything would be just fine, wouldn't it? We wouldn't have any more problems. But I heard some laughs. I expected more laughs. But so how do we do that? It is possible to ablate the immune system, and it's done by radiating the body or by giving chemotherapy drugs that wipe out the immune system, and then with a bone marrow transplant, put in cells that will then create a new immune system. This technique has been used for a long time for lymphomas and leukemias and some hematologic malignancies, and so why wouldn't it work for multiple sclerosis? And in fact, in clinical trials, it's been shown that it does have some effect. The problem is, though, that there's a lot of side effects to that. Wiping out the immune system with the radiation and with the chemotherapy certainly can cause a lot of problems. They're not safe procedures. Also, they don't fix damage that's already been done, and I think this is, again, something to realize with any of the treatments, but especially stem cells, that there's a lot of promotion on the internet that make people think that it's going to fix what's already broken, but that hasn't actually been shown to be the case, but rather to reduce the chances of there being more attacks. So, as I say, there are a number of clinical trials that have shown that it does, in many people, decrease the chances of having more problems from the multiple sclerosis. The interesting thing is that stem cell technology has taken a long time to develop, and it was very slow in the past because there were so many taboos against doing it. And during the time that it's developed and come to this point of some successful clinical trials, we have now more than 14 medications that do kind of the same thing. And so the challenge now is to compare, how does the effect of replacing your immune system with stem cells compared to taking any of the medications that we showed in the slides. I think that a lot of us have the notion that the stem cells may not be any better than that, or at least for most people, and certainly the risks are considerably greater than what we have with the new medications. Then there's the issue of stem cells to repair the damaged immune system. So rather than creating a new immune system, how about a stem cell that'll go in and fix the myelin, or a stem cell that'll fix those broken nerves? And there is activity that's going on in this area, but there's a whole bunch of unanswered questions, and this is still, I think, kind of Star Wars treatment. Lots of questions of where do you get the stem cells, what kind to use, where to put them. Should you put them in the spinal fluid or intravenously, or inject them directly into the brain? And then, how do you make those cells do what you want them to do once you get in there? And I think that this is a big issue with a lot of the stem cell promotion that you see, is that we do have techniques for isolating stem cells. We do have techniques for introducing stem cells to your body, but how do you make them do what they want to do? You know, I've often thought of it as, you know, you want to go to the moon, and so here's a rocket ship, and there's a little capsule up on top, and you climb in and light the fuse, and the rocket takes off, and maybe it'll get to the moon, you know, but there's a big gap there. Can you really make it do what you want it to do? And so I think that we're still, for that part of stem cell science, is still a ways off. Then there are other measures, and I think Dr. Shapiro will talk about some of these. We know that people with multiple sclerosis are more likely to have low levels of vitamin D. And there's a lot of evidence that the immune system is less likely to cause damage if vitamin D levels are at least in the healthy range, and maybe even a little bit higher in people with MS than in the healthy range. And so we generally recommend that because it's cheap and there's really not a lot of side effects to it. Lots of diet concerns, and I think the bottom line is what we recommend for patients with MS is a good, healthy, heart-healthy diet. It still has to be proven with clinical trials that one particular diet is better than another. And then there's vitamins and antidepressant medications, which actually may have some physiologic benefit, and a lot of other supplements and exercise and physical therapy, and perhaps Dr. Shapiro will touch on some of those things. So to summarize, we don't have any cure for MS, but we certainly have these disease-modifying therapies which can have a dramatic effect in improving a person's likelihood of living a full life, free of disability or with less disability than there would have been without these treatments, but all based on the earlier it started, the better. There are ongoing clinical studies that look at these other issues of how do you fix things that are already broken, how do we do an even better job, even safer. Managing the medical behavioral rehabilitation care is still a really crucial part of living a life with multiple sclerosis, and we'll talk more about that. And I think that the important thing, again, coming back to this idea, is that people with MS don't have a shorter lifespan overall than people without MS. And the things that people with MS die from are the same things that we all die from: heart attacks and strokes and cancers. So maintaining good health is really important, and we may hear a little bit more about that from one of our other speakers this afternoon. So that is the conclusion of my comments. Do we have time for questions? So let's start down here. Are there questions? Yes.
I've heard that there are silent exacerbations that people can have. Can that damage show up later on as we age and are less able to compensate for it?
That's a really good question. So the question here, to repeat it, is that can there be silent exacerbations, And do those exacerbations have an effect later on, even if they're silent? And absolutely, yes, 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 yes to both of those questions. That slide that I showed early on with all the little arrows, that shows that those are little attacks that are occurring even when a person doesn't know that, because they may not bring with them new symptoms, but they take away little parts of the brain. And there may definitely be a cumulative effect of that, of losing little parts of the brain, even if it didn't cause any new symptoms at the beginning. I've always thought that what happens over the span of someone's life, what happens to the brain is sort of a cumulative effect of everything that's always happened to it. You hear about NFL players who are unfazed by their injuries, but then when they get to be 50, 60 years old, they have neurologic problems that are the long-term result of those earlier injuries. And so multiple sclerosis may be one of those early injuries that affects how the brain works later on. Other questions?
Doc?
Yes.
No?
Yes, so the question here is, what about that life change? Multiple sclerosis is different in different eras of life. I mean, even in childhood, we know that the immune system is being geared up, even in kids, to then respond in early adult life with MS attacks. So that something is happening clearly even before that. The other question you asked, does everybody become progressive? No, they don't. We know that there are people that can have exacerbating remitting attacks and not become progressive. It's really uncertain what percentage of people will become progressive over time. And when we used to think that it was the majority of people, a large majority, will, by the time they're in their 70s or 80s, have serious disability from it. And I think that now, perhaps as a result of the medications that we have, less likely that that's true, but